All right, I wanted to fulfill some requests here. First one was about different types of lines. So I think this is a good one because we can go from tiny to huge, okay? So 99.999% of patients in the hospital are going to have some type of access, vascular access via a line. So I think definitely the most common we're talking about is a peripheral IV, okay? The antecubital fossa here is definitely the most common place where a peripheral IV ends up. And honest to God, if someone said to me, here, would you rather put in this peripheral IV or this central line? I would grab the central line kit because I've put in more central lines and invasive large lines than peripheral IVs in my career by far. So I'm not the expert at peripheral IVs. Our nursing staff is outstanding, obviously, because they're who put it in, along with our anesthesia providers, for sure. So a peripheral IV is, though, interesting, is measured in gauge. And so the diameter of the IV is like it's inversely proportional. So if you have a 14 gauge IV, it's 1/14 of an inch. So that's why a 14 gauge is bigger, a larger bore IV than like a 20 gauge. So that's 1/20 of an inch. So that's inversely proportional, which is different than some of the other things we're about to talk about. Because then we're going to talk about CVC, a central venous catheter. And those can be placed in the internal jugular, subclavian, or femoral. And so this is either sometimes a triple lumen. So there's 3 lumens that literally have these types of lines running through them. And those are typically going to be for vasopressors or like 3% hypertonic, saline, or TPN. Any of these types of caustic things that we can't put through peripheral IVs are going to go through a central venous catheter. And those are measured in French now. So that's typically like a 7.5 French catheter. And French is going to increase in diameter as the size increases. So a larger French catheter is a larger diameter catheter, okay? Then the next one is what we call a med comp, or a dual lumen HD hemodialysis catheter. So these are even bigger. They have 2 lumens and they're for hemodialysis. But the next most common one we use in trauma would be what we refer to as a cordis catheter. So this is also a type of central venous catheter, but it's a lot shorter and fatter. And so the typical test question, or rounds pimping question, if you will, is going to be, if you wanted to get me a massive transfusion and blood into my body as quickly as possible, which one would you choose? Well, truthfully, the large bore peripheral IV is, because it's short and fat. That's going to get us in quickest in comparison to like this triple lumen is super long, okay? So there's that law that I always forget the name about, but basically the resistance is inversely proportional to the length of the catheter, or excuse me, it's proportional. And then the radius, as the radius gets bigger, the resistance is going to go down. So if the length of the line goes up, resistance goes up. And if the radius or the diameter gets bigger, short and fat, then the resistance is going to go down. So that's why we want something short and fat. And then maybe over here, like the Mac Daddy of all these would be like an ECMO cannula. I don't even know the French size. Maybe somebody could tell me. Or like an Impella device. Those catheters are massive in their French size, upwards of. So the catheter for deploying like a TVAR is like, I want to say like a 20 or a 24 French catheter. So those are massive. But this will pretty much get you through. And then there's also PICC lines, peripherally inserted central venous catheters. These still count as central lines. So if there's an infection with any of these, they're called a catheter eclampsia, a central line associated bloodstream infection. And a PICC, actually, it didn't used to back in the day, but it does now classify as eclampsia. So this is what we absolutely don't want. All right, that's a breakdown. And again, all these lines come with their own set of complications, but I'll put it very plain and simple for you. I've seen a loss of an extremity from a peripheral IV for an infiltration and then requiring an amputation before. So that just goes to show you a more overarching theme of any and everything you do in the hospital carries its very, very much inherent risks of literally limb loss and death. And I think the more you approach things with that mentality in mind, the safer of a nurse, a doctor, anybody practicing in a hospital, any provider at all, the safer you become knowing that little bit of information.